volumes percent per deciliter. All right, we take that, we times this by cardiac output, okay? And then we get roughly 1,000 milliliters of oxygen delivered to tissues, okay? And this is basically standard from anywhere from ages 35 to 55, okay? Normal adults, normal metabolic processes, okay? So 1,000, all right? I'm gonna go over all of this, okay? 1,000 milliliters of oxygen sent to your body for metabolism. Another part of this, okay, is gonna be something called the respiratory quotient. It's roughly 0.7, all right? The respiratory quotient is basically for normal metabolic processes. All this means is that your body utilizes 250 milliliters, sorry, my arms are, hopefully you guys can see this, 250 milliliters of oxygen our body uses, and our body produces 200 milliliters of CO2 for normal metabolic processes, okay? So these COVID patients, they're obviously having a hard time oxygenating, right? So we normally start with 100% SAT, okay? That SAT goes around to the tissue, 25%, okay, is used by the tissues. And how do we know that? We know that because we know normal values, okay? Normal values, SVO2, okay, 75%, all right? Which means the blood returning back to the lungs and heart is 75% saturated with oxygen, all right? Now in comes COVID, all right? We have a red blood cell, all right? We have hemigroups, okay? And inside these groups, iron molecules, I don't know how well, hopefully you guys can see this okay. This is how oxygen gets its affinity for the red blood cell, okay? There are roughly 5 different types of hypoxia events, okay? Different things that can cause a hypoxemia and hypoxic events, all right? Now, with COVID, at first it was originally thought that COVID was actually directly influencing the red blood cells, breaking down certain types of lipid chains within these Faraday cages where these irons and releasing, and then they basically said, well, that might not be happening, blah, 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 blah. It's basically a very large shunt and dead space ventilation inside the lung due to all this histamine, this cytokine storm that basically gets initiated, okay? So these patients, they're going around and, oh, let me grab the next piece of this, okay? So this right here is the oxyhemoglobin dissociation curve, okay? So this right here is in our lungs, alveoli, right? This is normal, all right, what our PaO2 is gonna be. It's supposed to be 80 to 100, all right? All this means, all right, and here right here, this is your CaO2, right? This is your volumes percent, okay? On the left side, over here in the column, all right, we always know that we need to maintain a PaO2 of at least 60, okay? Because a PaO2 of at least 60 will give us a SAT of greater than 90, all right? Once again, all this means here is that you have a red blood cell and you have 4 hemigroups, okay? 100% means all 4 are loaded with oxygen, okay? At 75%, you have another red blood cell. Only 3 are loaded. At 50%, only 2 are loaded, all right? And so on at 25, and then 0, there's no oxygen's able to, there's no affinity for the hemoglobin, okay, for oxygen to get attached to the hemigroup, okay? So you notice at 60, this drops rapidly, okay? So going back to our equation, okay, of how oxygen travels, okay? Like I said, 97%, this is just another, and I'll have this for anyone who wants to look at it, okay? 97% of oxygenation travels on the cell, okay? This is all done by hemoglobin, all right? Majority of the body. It also requires a SAT, okay? So as the lungs fill up with cytokine, like this histamine release and cytokine release, what the body normally does when those lung units collapse, the body actually knows what's happening when there's no oxygen going to those. These atelectasis actually begins to start happening due to vasoconstriction in the pulmonary arteries. They sense that there's no oxygen transport. with COVID, for some reason, it's actually dilating those pulmonary vasculatures. And once it dilates these, due to all the histamine release, it's dilating them and it's worsening the VQ mismatch, okay? The dead space ventilation, normally we would not send any blood to these lung units that weren't working, but there's a lot more blood going to these lung units, so that's just worsening your shunt, okay? So these patients, they desat. So back in the spring, if you remember, all of these patients, they didn't know what was going on. They didn't even know they had COVID, right? Normal metabolic processes, they only require 25%, okay? 25% of this 1,000, all right? Now, if they become hypoxic or hypoxemic slowly over time, okay, your body goes through some changes, and we're gonna talk about that in a second, all right? But the hemoglobin, the transportation of the hemoglobin is the problem. So once this takes an effect and the lungs become junky, they're no longer functioning with a full capacity of hemoglobin, okay? So once this hemoglobin, all right, once this SAT is impaired, all right, remember, not their pulse ox, not their plasma, okay? Once this actual SaO2 is impaired on the oxyhemoglobin dissociation curve, they no longer carry this 1,000 milliliters going around their body, okay? Once one is empty, the entire red blood cell loses affinity for oxygen, okay? Basically, it doesn't want to function the way it normally should, okay? Instead of this 1,000, you end up sending 750. This is a cascade, and this happens to a lot of hemoglobin, and then 750 now is being transported. So instead of 100% SATs, okay, now you have a 75% stat you're starting out with, okay? Remember, this is not your SpO2, this is your SaO2, okay? There are differences. This goes to 25%, your body uses 25%. Now we have 25% returning back to the body. This is increasing the body's shunt, okay? This shunt becomes so large, okay, that it continues to affect more and more red blood cells. More and more shunting occurs, okay? And then it continues to affect the amount of oxygen being sent, okay? Now, this also happens in other forms of other diseases, okay? Anemia, for one, all right? Anemia, okay? And the first response in anemia is an increase in cardiac output, which is going to be this portion of this oxygen delivery system, okay? Your body actually just increases heart rate, increases blood pressure to just transport more oxygen around the body so it can offload CO2 and load on oxygen. That's done in the acute phase. Chronic phase of anemia, is an increase in DPG, okay? I have a hard time saying this or remembering it. I'm not looking at a piece of, well, I guess I could now, but it's like diphosphate glycol, something like that, okay? Basically, it's like an enzyme that your body produces, okay, to combat the anemia. But what it's doing, okay, is it's changing the oxyhemoglobin dissociation curve, okay? So with this curve, this nice sinusoidal wave right here, okay? Remember, we always want to target a PaO2 of 60 because that'll give us our SAT of 90, right? Here's a little cheat box that I usually tell the nursing staff, all right? PaO2, SaO2, 40, 50, 60, 70, 80. It's a lot to remember, so I try to give them little cheaters to kind of remember. But a SAT of 90%, a PaO will yield a PaO2 of 60 if nothing's going on, if everything's fine, okay? But that's not the case. So when we're getting these blood gases on these patients, these COVID patients, and their SAT's 98, 99%, their PaO2s are coming back in the 50. It's 50, 52, 53. But it's not supposed to be, all right? Well, there's a reason for it, okay? So with this normal oxyhemoglobin dissociation curve, there are going to be things that are going to change the shifting of it, okay? And basically COVID's causing a little bit of both, but it's causing majority of a right shift, okay? The right shift is due to increase in temp, which we know people get fevers with COVID, an increase in DPG, okay? And an increase in hydrogen ions, which is ultimately a lower pH, all right? So as this goes up, now that 60, okay, when it goes up, that 60 is no longer going to be your 90, all right? Your 60 is going to lower the amount of oxygen that's loaded onto the hemoglobin, all right? It's going to, remember This right here is loading 4, this is loading 3, this is loading 2, this is gonna load none, right? 1, none. All right, it's lowering the amount of hemoglobin, which essentially, once again, is affecting the oxygen delivery to the body, okay? Now, it keeps on happening. So these patients, how are they displaying, okay? They're displaying with these periods of like, they look like they're fine, and they have a SAT, like around 80, 89, 90%. And then all of a sudden they're getting tachypnic, all right? And so they're on these, we were originally using, regular cannulas, and then we're going, escalating to a high flow cannula, the green large bore tubing. This is kind of where I'm going to talk about little flow pattern states real quick, okay? Normal flow patterns for you and I sitting right here breathing a frequency of 10 to 20, okay? All right, we have tidal volumes inside our body, right? We use a certain amount of volume in our lung, all right? Volume is flow over time, okay? Flow over time just is 2 liters, 4 liters over 0.5 seconds, 0.8 seconds. That's how our lung is getting the volume due to negative inspiration, okay? And that's, everyone's different, okay? But this volume, this flow pattern is roughly 6 to 8 liters per minute for normal people. You and I right now, we're breathing through our nose and mouth at 6 to 8 liters. This is also why nasal cannulas are only effective up to 6 and 8 liters. Here in the hospital, we go up to 6 liters, and then we transition to a high flow cannula. So I tell the nurses, if they're on 6 liters, that they need to bump them up to the 8. The bubblers will handle 8 liters, and then you can hopefully subside their hypoxemia and then go facilitate getting a respiratory therapist to get a high flow cannula device in the room, okay? But the normal breathing pattern is 6 to 8. Now, when somebody is in distress, they can breathe in excess of 3 times the normal breathing pattern, okay? They can breathe in excess of 24, 30 liters of oxygen, all right, 30 liters a minute, I'm sorry, all right? So what does this mean? So an RRT is called, and a patient's on a 15-liter nasal cannula, all right? Now they're tachypnic, and they're breathing a rate of 36, and their flow is very, very fast. With that regular cannula, all right, or that high flow cannula at 15 liters, they're breathing 28 liters of flow, okay? They're essentially breathing 13 liters of room air mixing in with that. We all know this, all right? It's diluting the amount of oxygen we're giving. So what was happening? People were taking the high flow cannula off and then placing them on a rebreather, okay? By the way, there are no non-rebreathers in the hospital, okay? They're all partial rebreathers, all right, which are not giving 100% oxygen, all right? All 3 ports need to be occluded. If you take note, the bags on these rebreathers, they're never deflating because they're just pulling in room air from that 3rd port, okay? So as we go and we switch them over from the high flow cannula to now a rebreather, a partial rebreather, 15 liters, you haven't changed the gap. They're still breathing 13 liters through that hole in the mask. This one's closed, but this one right here is open, so room air is still rushing in there. Nothing has changed with the patient. So this is where we went to put the high flow cannulas with the rebreathers. When you pair both 15 liters and 15 liters, you are now officially giving them 30 liters of oxygen. It's going to be very difficult for them to outstrip those devices, okay? So this is where, now obviously before COVID, we have a policy in the hospital, we don't keep masks on patients for longer than 24 hours or something. So this is where high flow cannulas come in, okay? When I say high flow cannula, there's an actual definition for true high flow devices, okay? And the definition is a device that will meet or exceed a patient's inspiratory demand at a fixed concentration of oxygen. So that means no matter what breathing pattern these patients breathe, the device will meet their inspiratory need at a fixed concentration of oxygen, which means we don't have to worry about over-oxygenating them. We don't have to worry about under-oxygenating them. The devices will be there for them regardless of their breathing pattern, okay? And these devices, the OptiFlow can range anywhere from 30 to 55 liters, okay? The OptiFlow is basically like 1st gen technology, all right? They don't offer a lot as far as like, they're really just kind of primitive, I guess, like compared to the ones they are now. They're still doing their thing though. Vapotherms are nice. Vapotherms like 3rd generation, okay? And these Vapotherms can deliver 40 liters, up to 40 liters of fixed FiO2 and heated humidified oxygen, all right? Now, one thing about the Vapotherms, it's set at 40, but there's actually, Vapotherm's patented technology, it's high velocity flow. It actually is delivering 180 liters of flow, okay? And there's a lot of information which I brought here, if anyone wants to know anything else about Vapotherms. But essentially, these devices allow the patient to kind of go through these breathing patterns that they're kind of going in without outstripping the device. So the device is really focusing on the patient's work of breathing, and the device, to meet their need, will make sure that they don't go hypoxemic, okay? The reason why we don't want them to go hypoxemic, okay, is because we have a Krebs cycle, right? What do we need for the Krebs cycle? All right, we need oxygen, right? And we need sugar. All right, what is the byproducts of the Krebs cycle? Carbon dioxide and water, okay? In the absence of oxygen, remember, so they're dealing with a chronic hypoxemic event, right? They don't know what's going on with them with these COVID patients, right? And their values, their oxygen delivery is impaired, okay? Which means they're all basically walking around like these pulmonary hypertensive end-stage COPD patients that have very, very little reserve. These people get short of breath and winded just by walking from one area of the room to the other, right? They have no reserve. The Krebs cycle, so if we make sure that we don't top off their oxygen, okay, oxygen's not diverse, it doesn't go to the body, just everyone gets whatever they want. It's gonna go to major organs first, and then it's gonna go to the extremities and whatnot, okay? But what happens is if the Krebs cycle goes unmet with oxygen, okay, it's gonna go into anaerobic metabolism, all right? Anaerobic metabolism is metabolism in the absence of oxygen, all right? Lactic acid is gonna start to accumulate. You and I, we would accumulate lactic acid if we jumped on a treadmill, just the same as anybody else. The problem, okay, with these patients doing this slowly over time is that in the spring, if you remember in the spring, all of a sudden, all of these patients, these even younger patients, they were starting to code, and they were fine one day, and the next day they're tanking, right? If in the spring, everything got nice out, people started walking their dogs, everyone started going outside, going back to the gym, whatever it is, right? As soon as you go and change a patient's physical, they go and exercise, they do whatever, they are changing their respiratory quotient, okay? They're changing the amount of oxygen their body is going to utilize and the amount of CO2 their body is going to produce via Krebs cycle, okay? So instead of this patient, okay, which is normally now, let's say COVID's gone and take its hit, it's impaired their oxygen delivery down to 500 milliliters. So now they're dealing with 50%. Their body still only uses 25% or 250 milliliters of oxygen. Now they go and work out. Well, now the respiratory quotient changed. Now they're using 350 milliliters of oxygen, right? And now they're producing 300 milliliters of CO2. Well, now instead, now this is going to go up. This is going to go to 35%. This is going to lower. This makes the shunt completely not workable when patients are in this state, because their lungs there's such a large shunt and dead space going on. They're basically saying all these patients are responding to that change in altitude with high altitudes with hypoxemia. All right, it's hypoxemic hypoxia. Okay, you can't get the P big A O2 to the P little a O2. You can't, this alveolar, it doesn't cross through the alveolar membrane, the alveolar capillary membrane that well. All right, so these patients, all of a sudden they just tank, all right? And they sit there and they breathe hard. At these points, their lactic acid is gonna start to rise. As soon as the lactic acid starts to get out of hand, all right, lactic acid is a fixed acid, okay? It needs to be excreted through the kidneys, okay? It can't go out anywhere other ways. It's either that or it needs to be diluted or buffered, okay? So these patients, and there's a half-life of 6 hours with lactic acid. So these patients, their bicarb is gonna start to take a toll, okay? So I try to tell the nurses with these patients on the chemistries, and we use normal daily chemistries, okay? CO2 is always on there. All right, we trend these in metabolic acidosis, DKA patients. This is how we trend their bicarbs. We don't trend them, okay, by getting ABGs. We don't trend them by they're not accurate. Everyone doesn't realize that the arterial blood gases are calculated plasma concentrations, okay? That is not an accurate total bicarb count. It's going to be close, but it's not an accurate. We don't trend these particular diseases this way. We trend them with the CO2 on the chemistries. We take that, we times it by 0.03, all right, and we end up getting total bicarb. It combines the bicarb on the cell and the bicarb. The CO2 that's in that is actually measured on the cell. The ABGs, it's calculated in the plasma, okay? So normal CO2 is roughly 22 to 26. So let's just call it 24. As this lactic acid starts to go up, it needs to be buffered if it's not going to be diluted. The same thing happens all the time. People who get massage therapy, what do they tell you to go out and do after massage? Drink lots of water. You're going to have flu-like symptoms. You're going to have body aches. That is just the production of lactic acid being released, okay? So now this lactic acid goes up, they feel like crap, and it's going to start to be buffered. Their CO2 on their chemistries is going to start to fall. It's going to start to fall. It's going to start to fall, okay? Why this is important, okay, by trending these labs, all right, is because your body always needs to maintain a 740, 40, 24, all right, pH, all right? This is pH, this is CO2, this is bicarb, okay? Your body's always trying to maintain this. So as bicarb goes and falls to 18, your body says, oh my God, I don't have a lot of base, it's getting eaten up. I need to blow off my volatile acid that I have in my body to compensate for 740, to maintain 740. This portion is maintained in the primary chemoreceptors in the brain, okay? So in the brain, we got a brain here, and we got a blood-brain barrier. Inside this barrier is pH changed by hydrogen ions and CO2, okay? So if you jump on a treadmill and you're increasing your Krebs cycle and you start to produce more CO2, your pH starts to fall, your body says, increase your minute ventilation via frequency and tidal volume. This tidal volume is an increase in flow and time, okay? So I'm just trying to make sure, I'm just trying to connect the dots on how all of this is very relevant. All right, outside this is bicarb, okay? Bicarb does not actively diffuse into cerebrospinal fluid, okay? So this is the primary way we regulate our pH, all right? Now, when these patients, the problem is obviously the age types and comorbidities with these patients, right? Some of these patients don't do well and some are okay and their body can combat it. It's their work of breathing in some of these labs that are going to help us kind of trend how well they're responding to the therapy and how well, if we're meeting their oxygen need, okay? When this starts to go up, the CO2 starts to rise, your body increases its metaventilation to maintain this 740, okay? Let me see, where do I want to go next? And I'm okay. You guys, if anyone wants to ask a question, please, like this is usually I do this in small groups with like 3 or 4 nurses. So I'm not used to just talking to a camera on the thing. So this is usually a very kind of like longer conversation with the nursing staff, because they ask questions, because once I can stimulate their thinking, everyone's thinking and processing everything differently. They try to ask questions how it correlates to the way they do the way they work. So if anyone has any questions on something, please like speak up, because the more I kind of like talk about this, the more that people might get confused. I'm just being honest. So I don't really know where I want. Okay. So another thing that I was talking to nurses about is, I know you guys started bundling your care. You know, and that's with these COVID patients. A bunch of RRTs were called on a patient 3 days in a row on 7 South. And if you take note, one of these guys, this patient, he had a lot of comorbidities. He was a frequent flyer, okay? And we were bundling his medications. This gentleman, he was doing fine. I mean, albeit he was sick, right? He was on a 10-liter high flow nasal cannula. But an RRT was called, and every single time the RRT was called, it was about an hour after he received all of his medications at once, okay? So all these people, they have compensatory mechanisms, right? Compensatory mechanisms is what is allowing us okay, to combat the oxygen need in our body, okay? Remember, an increase in cardiac output is required for anemic states, okay? So if you have people that are on a bunch of heart medications, metoprolol, beta blockers, calcium channel blockers, high blood pressure medications, if we give them all of that, we ruin their body's ability to deliver oxygen in a state where supply is very, very limited, okay? This is a supply and demand issue. The demand is changing when these patients are getting up and going to the bathroom, okay? It's changing because they're getting up and changing their respiratory quotient, okay? So in these states, they get up and go to the commode and they're on a high flow cannula, they're literally teetering with a sat in the 90s, 91, 92%, and then they are plummeting this. There is oodles and oodles of information out there on reasons why. Right here is O2 consumption. I'll have a printout here. Okay, agitation, pain, shivering, work of breathing. When your work of breathing goes up, your body actually utilizes 20 to 30% more oxygen. All right, with shivering is the worst one. Shivering, your body uses 300 times more oxygen during shivering, okay? They've literally gone and trended this information, giving real-time venous saturation samples and PaO2s or PVO2s. And they're seeing that basically on the oxyhemoglobin dissociation curve, that during patient turning and during shivering, these SVO2s, which are normally 70%, 75%, are plummeting into the 30%. Okay? That is completely ruining our shunt. Our shunt now is at the point where it's going to take a half hour, an hour for these patients to catch up. They're responding like those end-stage COPD patients, every single one of them. Responding like they just decompensate so fast. And it takes forever for them to get their sats back up because they have no reserve and their oxygen carrying capacity is so limited. And some of the medications, they all need to be on them, of course. I'm not saying to stop everyone's medications. I'm just saying, obviously there's, guidelines giving metoprolol, blood pressure medication, heart rates. If somebody's got a heart rate in the 50s, and we're giving them Precedex, if we turn the Precedex off and their heart rate goes up to the 60s and 70s, is that such a bad thing? I know that they're going to wake up a little bit. I'm just saying that everything is not as cookie cutter, as the next patient down the line, because we're changing these cardiac output issues, okay? And then it changes the way that they deliver the oxygen around the body, all right? And then with these seizures, arrhythmias, fevers, all of that is changing their O2 consumption. Is this all making sense, to everybody? I don't even know how many people are even on here. Did everyone log off?
There's a lot. No.
Oh, is there?
No.
Isn't it? I don't hear anybody, so I don't know if anyone's. I mean, you can speak. Is this? Everyone's like, no, I don't really. I'm barely paying attention.
It's good.
I'm just okay. So I don't just kidding. So another thing too. Okay, so the histamine release. Okay, the histamine release is these. What they're finding is that after the histamine release, is that number one is going to be histamine, and then number two is going to be this hypercoagulable state. All right, clot. Everyone's clotting, right? They're finding that people with liver impairment, okay, cirrhosis, fatty livers, okay, hepatic injuries, all right, they're not able to. A lot of the clotting factors are all developed in the liver, all right. So they're at risk. They're basically finding that certain people with certain disease types are at risk. All right. So liver issues. So I always tell people if you got somebody with liver issues, they need to be watched carefully. Okay. I have other information here that will back all this up if you guys care to read it on your own time here. Why are they talking about asthma? Right. Asthma, bronchitis. All right. Why do these patients don't fare well at all when they get COVID? It's because since this is a histamine release, okay, with cytokines and other pro-inflammatories, okay, this is all histamine issues. So if a patient with COVID goes into an asthma exacerbation or bronchitis, okay, they increases their body's ability to get rid of the COVID virus. Then now they have to deal with a different type of a leukotriene, okay, a different mast cell stabilizer, all right? And inflammation is just run amok, and your body cannot combat it, all right? Your body combats these things, okay? What happens when we're starting to see these ferritin levels, all right? Let's talk about ferritin. When these patients, when these histamine gets released and these these inflammatory markers rise, all right, we're looking at ferritin, all right? Ferritin starts to increase. Your body has a normal ferritin level of less than 300, okay? That's because red blood cells die every day. When red blood cells die, it releases iron, all right? It turns into, iron is it causes a lot of oxidative stress and inflammation, all right? So your body creates this ferritin to combat, okay, with all of that, those issues, okay? The ALTs, we're noticing in these patients ALTs here. ALTs are starting to increase. The ALTs are increasing because of just the liver issues that are being caused with the coagulable states and all the clots, they're okay with everything. The hemoglobin, all right? With anemia, polycythemia, all right, patients, they tend to start to produce, they ramp up their bone marrow, they ramp up their hemoglobin production, okay, so they can carry more oxygen around to the body, all right? So certain things, and remember, hemoglobin is going to greatly affect the oxygen delivery of, the CaO2 that I was going over before. All right, so asthma, all right, is going to be a big problem. Now, your body has three different ways to get rid of this ferritin level, okay, which is the anti-inflammatory, it's created from the inflammation. One, the macrophages of the lung. All right, two is the type 1 alveolar cell walls. These are packed with ascorbic acid. All right, vitamin C, right? Why do you take vitamin C? Vitamin C, all right? And third one, okay, is the liver helps deal with the ferritin, all right? Because it has something, this is oversimplifying it, an iron vault of sorts. So the ALTs start to go up because the liver is trying to carry on all of this ferritin, it's trying to take on to combat all of this ferritin issue. And your liver enzymes, so that's going to be another indicator of how well the patient's able to deal with how their liver status, basically, is how well they're going to be able to deal with all this excess ferritin. And we're seeing these ferritin levels in these C-reactive proteins, they're spiking in these patients. They're going anywhere from 300, and they'll double overnight, they'll triple overnight. We've seen them in the ICU, they're 2,400, 3,000 ferritin levels, okay? Like, that's how much inflammation is going on in these patients' bodies, And then now they got that hypercoagulable state with liver issues, and they're just going to be clotting all over the place. And it's the histamine that is just gunking everything up and causing all of these other issues. Hopefully this is all making sense. Emphysema, all right. Remember, I know I kind of beat a dead horse with this, okay? COPD, all right, chronic obstructive pulmonary disease. This is an umbrella, and this is what I tell all the students, okay? Underneath this is CBABE, all right? Cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema, all right? All of them are COPD. I have asthma and I get bronchitis maybe twice in my life. I'll be labeled with COPD when I'm older, okay? Even though I've never smoked a day or a thing in my life, okay? I'll still be labeled with this. It doesn't even matter. The treatments are different though, okay? The treatments for emphysema, that's a diffusion defect, okay? So if this is a diffusion defect, they're gonna have a hard time, going in and back and forth with the oxygen, not necessarily carbon dioxide all the time, okay, but the oxygen itself. Asthma, histamine issues, okay? Liver, we don't really talk about, cystic fibrosis or whatever. And bronchiectasis is just another horrible form of bronchitis that does transformations of the airways, varicose, secular, cubiform. Lost my train of thought, nobody's talking. So much easier when people are talking. Blah, 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 what was I gonna say? Oh, why are we trying to keep these people off the ventilator at all times, right? We try to keep these people off the ventilator because the ventilator, we have normal way of doing things. A negative intrathoracic pressure, transpulmonary pressures are always negative below atmosphere. We suck the air into our lung, creating a vacuum. This promotes venous return back to the heart. It promotes proper filling for your lung, proper filling for your lung, but proper filling for your heart to pump blood to the rest of your body. When we go and change that process, okay, we put people on positive pressure ventilation, they end up decreasing venous return, obviously, decreasing, blood, basically, blood. I'm sorry about my handwriting here. I got this tripod in between. It's like kind of tight in here. I'm usually like my arms are kind of tight. You're pushing air into somebody's lung, okay? You have alveoli, all right? When the air goes in with all that mucus, this alveoli over here might have a whole bunch of mucus in here, and this one here might be open. All that's going to cause is overdistension, all right? Or air will get pushed in here. During inspiration, airways dilate, okay? So air gets trapped in here. On exhalation, it gets forced out. This one gets bigger, but it gets bigger. This is where I can't tell you how many pneumothoraxes and mediastinal pneumothoraxes have happened since COVID on these ventilators. It is ridiculous. Like I keep telling them, like literally, I feel like 90% of the time when I'm in ICU, I'm either trying to get people extubated or trying to lower the amount of PEEP they're on because we have yet another pneumothorax or yet another mediastinal pneumo from these. And so there's like a lot of controversy between, high PEEP, low PEEP, ARD, ARDS, NET studies, okay? But basically it's saying there's really, and I have all this other information if anyone cares to have it, there's really no studies or guidelines saying that all of this PEEP is necessary. It does not improve your mortality or morbidity in these patients, these COVID patients, okay? If anything, we're inducing more harm. And the more overstretching that happens, okay, all it does is increase its histamine release, okay? It will ruin those type 2 alveolar cell walls that are already getting destroyed by the COVID, all right? We have these little pores of Kahn that go and let these alveoli communicate, all right? They communicate via this pores of Kahn. These go and opened up, and then you have one big alveoli. This is exactly what happens to emphysemic patients throughout the course of their life. They smoke, all right? The smoke is diffused and ends up embedding itself into the parenchyma of the lung, ruining type 2 alveolar cell walls, creating blebs, okay? Then blebs, bullies are bigger than blebs. Blebs turn to bulli, okay? And then you end up with these very large bulli. That is a reduction in surface area of the lung, which is affecting their VQ mismatch in diffusion in the lung. Emphysema is a really difficult one. But with the COVID, what do? We put them on a vent and we put them with large amounts of PEEP. PEEP will kill COPD patients. If you put somebody with emphysema, if you increase their PEEP, okay, it ruins their lung to the point where they're gonna be vent dependent for the rest of their life. I'm not lying to you, okay? Because they have blebs that have been formed for the last 10, 15 years, and we're just gonna blow them up and we're gonna make them huge, and then we're gonna blow, and eventually you either end up getting a bronchopleural fistula due to the COVID because it can't escape, right? Or they end up vent dependent. We can't get these PEEPs, these high level of PEEPs down, okay? So emphysema is a big one, or they do not do well either. The other, there's some other ones too. Cardiac issues, CAD, okay? This is gonna go back to the cardiac output issue, all right? With the cardiac output, if that's impaired or they go into an arrhythmia, okay, this is gonna go back to arrhythmias are causing that O2 consumption, okay? There's arrhythmias. Anybody with AFib, it's gonna change basically how their oxygen is gonna be divvied up in the rest of their body. Let me see, the resting physical dissolved in plasma. There we go. So this right here, like top of this is it. This is the much oxygen that's in the alveoli. This right here is O2 in the dissolved plasma. Remember, your hands, all these pulse oxes, they all get the leftovers of the oxygen, all right, when they're in these states. So all these pulse oxes, they're widely irregular, right? They're just going out of range. This all has to do with this because this oxyhemoglobin dissociation curve. Normally those venous pulse oxes, okay, I'm just explaining why the pulse ox is so unreliable at the moment because, this is going to be funny, but all the pulse oximeters, they are completely inaccurate below 75. They don't have the capability to measure oxygen on the cell below 75%, okay? So when it's reading 50%, 20%, 13%, it could be 0, it doesn't matter. But below 75%, you really have no idea what it is, okay? But it's just saying that it's bad. The reason why that is because The venous set, remember our body uses 25%. The venous set is always hovering around this 75%. It's usually never that low. But in the state of these COVID patients, where this right here is, think of this as the lung all the way down to the arterial capillary membrane, all right? It's always hanging around here. It's not anymore. Tissue at rest, okay? It's no longer hanging, right? It's supposed to be a PO2 of 40. It's not. It's gonna be way down here. The sats are gonna be way down here. And so the goal is to give these patients as much oxygen as you can to meet a pulse ox. They're recommending a pulse ox between 92 to 96%, basically at all times. Vapotherm has come out with guidelines on using the Vapotherms, and they're saying that these patients, they're finding these patients are on these Vapotherms for 8 to 10 days, 70, 80, 90, and 100% oxygen, and then after they their body starts to kind of deal with the histamine storm, and they start to heal and they're responding well to the medications, and they don't have any other issues going on that's going to stop that from happening, they can be weaned off of these Vapotherms. But here in the hospital, the one of the biggest things, everyone kind of does things differently. So tell a nurse, so it's really difficult for your nursing staff to get an idea of why are we taking the Vapotherm off this patient? We just put them on it like a day ago, you know? It's not, well, they don't do well if you take them off, and it has to all go back to that flow demand, that flow. Once we're not meeting that patient's inspiratory flow demand, we put them off from the Optiflow or Vapotherm to a high flow nasal cannula because we could get them out of the hospital with a high flow nasal cannula. But that doesn't necessarily mean that that's going to be the greatest idea. So it's always wean oxygen as tolerated, but when they don't tolerate it, we need to be going and keeping. So basically saying, leave these patients on these Vapotherms for 8-9 days. The ones that are critically ill because they're teetering to the point where they're either going to get, go to a BiPAP or they're going to end up getting intubated. But we're not really doing them any favors by taking it away, because they're meeting a SAT of 90%. That's not the goal, because the 90% SAT is not going to be accurate. The SAT is widely variable, all right? And it all just goes back. So we started using these partial rebreathers with the Vapotherms, right? I'm trying to tell the nurses to just think of it as 100% oxygen button on a ventilator, okay? On the ventilators, we tell them in nursing staff, they learn this in school, with patient suctioning, patient turning. You walk over to the vent, you hit the 100% oxygen button. This hyperoxygenates them and kind of tops off their hemoglobin so they can go and they don't go through these nasty plunges during the patient turning, okay? So I told them to use that partial rebreather bedside, okay? And let them wear that. If, let's say you gotta get them up to a commode, put that on them for 2 minutes, hyperoxygenate them for 2 minutes, get them over to a commode, and you're still going to get a DSAT because they're still changing their respiratory quotient when they're getting up and they're demanding more oxygen. But you're going to stop them from going into this hypoxemic event. And that's the hypoxemic event is what's causing their changing in flow patterns and what's causing them, they're not on the right device at that point. As soon as that happens and they're not on a Optiflow or Vapotherm, they're not going to do well and they might not recover. And this is where the RRTs are being called, because they're not on a device that's in the room. We have to go to an Optiflow or Vapotherm. So if they're just on a regular cannula or a regular high flow cannula, have that rebreather in the room and have it ready so when you get that patient up, bring them over, put them on that oxygen, let 1 minute, 2 minutes go by, top that bad boy off, and then get them over to the commode and let them do whatever they need to do, because we obviously want to promote independence with these patients, because it has been shown that keeping them independent, letting them do self-turning, all of that stuff improves their quality of care for themselves in the hospitals. But at the same time, if they don't tolerate getting up and they're falling and they're having these hypoxemic events, which is leading to these RRTs called, which is a strain on resources in the hospital, it's really just kind of pre-gaming any kind of care or additional care that you want to do throughout the day just with that partial rebreather. Does that make any sense? I'm kind of saying, I don't see any faces, so I'm like, I have a hard time. I'm usually, okay, does that make sense?
Yeah, it does. Yeah.
I mean, I think that's gonna kind of be it. I mean, I usually talk to a lot about other nurses, but you guys they're all managers, right? Yeah.
Not all.
No,
There's some floor
yeah.
nurses.
Oh, they are? They're also floor nurses?
Yep.
So, looking at CO2, all right, on your chemistries, okay, that'll give you your bicarb. This equals bicarb, okay? You want to know what this is all the time, all right? FCCS guidelines, okay, the very first clinical sign for a patient's impending doom. Does anyone know what it is? I always preach this crap. It's tachypnea. It's breathing fast, okay? What's the classic thing? What's a classic disease that we know that does this, right? DKA, right? DKA is a metabolic acidosis due to an increase in ion gap, okay? So when we close that gap, everything's hunky-dory. But when these DKAs are going on, these patients are 6.9 pH, right? 15 CO2, right? Their bicarbs are 9, okay? What are they breathing? What's the breathing pattern? This is why it's so important to just recognize breathing patterns. They are breathing in a Kussmaul's breathing pattern, okay? The Kussmaul's breathing, their PaO2s, by the way, are like 115 on room air, okay? I'm not even going to go into why that matters, but it's important to recognize the fact that these patients are on room air and they're pushing their PaO2s well past what is normal because they're reducing their CO2 so much. But the breathing pattern, okay, goes back to that primary chemoreceptor stimulating their drive with an increase in tidal volume and an increase in frequency, okay? That's the breathing pattern. This response, okay, due to the bicarb is the same thing that's going to happen with these patients if the lactic acid starts to go up. If you have a lactic acid and it starts to be 5 and it is not addressed either by fluid, which you might not be able to give because they might be fluid intolerant, okay? You have to wait 6 hours, okay? You could give blood, that would help. Back years ago, the reasons why we don't give bicarb to people, at least it's not really used anymore, is because they showed that lactic acid, accumulation of lactic acid actually slowly creates bicarb, okay? So they used to give patients lactic acid to actually increase their bicarbs. But the problem is that if we cannot fix whatever is causing the lactic acid to rise, okay, either let's say we're just masking it with fluids, okay? I had a patient in ICU, and poor little lady, she was doing great on room air. She was 90 years old. She was doing great on room air. And they did an XLAP, and she ended up being 20 liters positive after the XLAP, which is normally gives patients fluid. She had an EF of 20% or 18%. All right, she was so puffy like a balloon. Her lactic, okay, before when she came back was like 15 or 18. All right, they gave her all of this fluid, and the lactic was falling. Huzzah, right? Everything's great. The pH is going to be great because now the bicarb won't be affected by the lactic, right? Well, then all of a sudden the next day they're like, holy cow, okay, we got to stop giving all this fluid. Got an ABG. The bicarb is low, really low, and the lactic acid is still there at 17. Okay. As soon as they turned the faucet off from diluting it, we actually never corrected the original cause for the lactic acid. Okay. And the cause was a bad heart. So the idea was thought that we took her to cath lab, and we put a balloon pump in her. Lactic acid came down after we restored cardiac output. So she's probably, and this is just a guess, but assumption, she's probably increasing her lactic acid due to poor perfusion globally within her entire body. Okay, but these patients, they're all responding the same way. They have to increase their breathing pattern, okay, to go in. So before we took this patient to cath lab, I got a gas on her. She was like 706. Her bicarb was 6, right, and her lactic was 17. And I was telling the cath lab nursing staff, I said, I'm going to increase the rate because right now she's breathing a minute ventilation, right? A minute ventilation on the vent of 20, okay? But when they go to cath lab, they give these patients a little bit of Versed, or they try to put them in a twilight sedation to make them more compliant with the cath lab. I said, if you're going to do that, she's going to stop breathing above the set rate. She's going to cut her minute ventilation in half and breathe 10. if she does that, then her gas, which is 706.15, and her bicarb was 6, right? She's working her best to try to blow off as much carbon dioxide as possible. But if we go and knock out her drive, this rises rapidly. It's going to go to 35, which may look normal, but what it's going to do to your pH, it's going to dump your pH. This is why a lot of these people that go to the interventional radiology, if you don't actually see the foresight of them using some type of sedation or anesthesia med that's going to lower their work of breathing, and they're driving in these people where they demand it, you have to go and pregame them with bicarb. So I'll be honest, I speak up. I said, she honestly needs some bicarb before we leave her, or she's going to code in cath lab. And they gave her 2 amps of bicarb, and I was like, great. And she didn't code. And her blood, guess what? It also fixed her blood pressure, because when her pH was this low, she was on 0.6 of levo, okay? Or yeah, levo. And they were just going up to 0.65. It's not working when your pH is this low. So they were like, let's start Epi. I'm like, I don't know. It was a really like rough situation, I guess, because I had to watch this poor little lady kind of go through this. She ended up dying, obviously. But from a withdrawal of care due to from her family, which is fine, But it's just that the cath lab nurses, they even recognized, because when I was talking to them with the resident, they were appreciative. Like they're like, yes, because they know this type of thing happens all the time, with these patients. So like, all of these patients are responding with these breathing patterns, and we go and control that breathing pattern at some point. Then we're going to ruin those compensatory mechanisms that are allowing them to increase their oxygenation and try to combat acidosis that we may or may not have caused, indirectly. Hopefully this is helping. I know this is kind of like, it's not all about COVID stuff, but more just how important it is to recognize breathing patterns, okay? Ataxic breathing, Biot's breathing, okay? There's those 2 breathing patterns right there are from lesions, or infarcts in the brain affecting the pons and medulla. The ataxic breathing from chronic narcotic use. Okay, so what we're seeing, these people that we can't wean off the ventilator, we put them in CPAP, and they're like, breathe, 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 pause, breathe, breathe, pause, breathe, 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 pause. That goes away in like 3 days once we stop narcotic use. It's like, it's documented, So, and then it kind of goes back to the COVID patients with how to manage a ventilator, not keeping them sedated, too long on narcotics because it's going to lead to vent dependent, but keeping them compliant. I'll be honest, the proning thing with these patients, that is a majority. That's the majority of the pneumothoraxes and mediastinal pneumothoraxes are from proning. These patients on higher levels of PEEP. Okay, when you flip somebody on 18 of PEEP, and let's say they're the what do you call them? The meds that you guys deliver, on the IV pole, your pumps.
Oh, pumps.
Your pumps go out, and let's say your sedation stops for 2 minutes, 2 seconds even. It doesn't even matter. If they wake up when they're prone on 18 of PEEP, I try to make the nurses laugh. I said, if they cough, if they fart, they can do whatever they want on a vent. If they do that on a vent on 18 of PEEP, they're going to pop their lung every time. Okay, because it is so aggressive. That much PEEP is so difficult to let them cough. A normal cough cycle, you generate 100 miles an hour of wind. 100 miles an hour, that's how aggressive coughing is. You try to cough like that on 18 centimeters of water of pressure, all of that force is just transmitted to the bronchopleural space, and you end up with bronchopleural fistulas. And the worst ones are mediastinal pneumos. And a lot of times we're not even putting chest tubes in these patients because of the risk of putting chest tubes in these patients. So that's just my own thing about, so when these patients are being prone on this PEEP, keeping them down at all times is imperative. I cannot, you can still do it, but they have to be down, down. And I know that sometimes, we try to lift sedation, but I'm basically finding out we're trying to lift sedation when somebody was being prone. And that's how the pneumothorax happened. I'm like, well, why are we even bothering to try to lift sedation? So I hope this is helpful that, maybe you can talk to, your nursing staff. It's to try to help, guide them. I'm not saying one way is better than the other, whatever, but everything is just not as cookie cutter as it is. And I feel like, when studies come out, we try to do something to help these COVID patients. Everyone is not prepared to manage it. It's fine that we do that, but managing them, it comes with a certain you need a lot of eyes on, and with the staffing, it's difficult, you know, and so I get that. I don't know. Getting them on the ventilator is probably the worst thing. That's why it's so not recommended. You know, obviously intubate them if it comes to that, and don't delay intubation. But we need to be a little bit more careful with how we intubate them. If that makes any sense, hopefully. I'm just talking too much.
No, no.
Does anyone have any questions? I know this is a lot of information. It's probably, oh look at it, it's 11 o'clock. Time for me to go. No questions? Nothing?